Hi guys, I am going to do a short video on labor and birth, and this is to accompany our preparation for exam one. So the PowerPoint that we're going to use to kind of guide our discussion with this or one-sided discussion on this is going to be the exam one PowerPoint that I'm going to share. Okay. All right, so what we're going to talk about has to do with labor and birth. Okay, and so when we think about labor, the thing that we're going to start with is we're going to think about the things that can affect labor. And these we call our 5 Ps. All right, so our first P is our passageway. This is how the baby's going to come through. So this is our birth canal. This can be the pelvis. This can be the arch, like the pubic arch. Okay. Our pelvis can affect our process because if we have a nice gynecoid pelvis, then there's a lot of space for that baby to come through. But if we have a pelvic shape that's flatter, like a platyploid pelvis, that can affect whether or not the baby can come through. Okay, so that's our passageway. Our passenger is our baby. All right. And there's a lot of things having to do with our passenger. What size is our baby? Is it too big to fit? What position is the baby in? Okay. And it's not just about whether or not our baby is head down or breech, but it also can be if the baby is in a position that helps the head to flex so that the baby's head fits through the pelvis better. Because the way that the head is shaped and the shape of the pelvis is going to affect our process. Okay. Also, our passenger can be considered our placenta as well, because that's also going to deliver through the same way. Next is our power. So our power is what is bringing the strength to move this baby down and out. And so the majority of our power is contractions, but mom's pushing effort counts as power as well. All right. Next in our list is position. And now we're thinking about mom's position. So if mom is up and moving, especially in early labor, that can help get the head to engage down into the pelvis in a better position to bring the baby down and out. Even a mom that is in bed with an epidural, we're often changing her position from side to side. We can put a peanut ball between her knees to open her pelvis to make space. A lot of different things with mom's position helps facilitate labor. And then the last P is mom's psychologic response. How is mom coping? How is her pain management? How is she coping with not just the pain, but the whole situation? Some moms get very overwhelmed and things like that. And if she's tense, her muscles are tense, that affects the way the baby comes down. The cortisol and different things her body can release if she's stressed in labor can affect her labor process. So those are our 5 Ps. Okay. When we think about our signs that labor could be starting, so one of the things that can happen before labor starts or as labor starting is called lightning. Lightning is when the baby drops down into the pelvis. Okay. Bloody show. So the cervix, you guys learned, is when a non-laboring cervix is usually thick and closed and it's holding that baby in. And as labor begins, or as this is starting to soften, okay, little tiny capillaries that live in here can break, and we can start seeing what they call bloody show, which is just a little bit of blood mixed with mucus that they notice on their tissue. It's not like a period. Okay. The cervix can become softer. And so for patients that aren't laboring naturally, sometimes that's one of the things we do to try to help get labor started is to soften that cervix. So the cervix can soften, we get some bloody show, and that can be a sign that labor is going to be starting. All right. So labor, how do I know? All right. I can't tell you how many patients have come in, they're having contractions, they think they're in labor, and they go home. How do I know to send them home? Okay. So the thing with true labor versus false labor. All right, there's a few things that affect this. One of them is like the magic answer, the very magic answer. How do I know? Is their cervix changing? Okay. There's other things that can be clues. So if her contractions are regular, if they're getting stronger when she does things, if I send her walking and her contractions are getting stronger, more frequent, that's a pretty good indicator, because usually false labor contractions are irregular and they kind of space out if I send her for a walk. Okay. If I hydrate her, if I give her, say, hey, go ahead and drink some of this, let's get you hydrated and see how you do. If those contractions stay consistent, those might be true labor. A lot of times false labor putters out with hydration, rest, position changes, all of those things. Okay. So these are all things that can be indicators. Also, if she's feeling her contractions in the lower part of her belly and it's radiating like towards her back and down her thighs, those are usually true labor contractions, where false labor contractions are kind of all over the belly. All right, so that's kind of how I can tease it out. But ultimately, it's going to be the cervical change. So if I have a patient that comes into the hospital and says, I think I'm in labor, we are going to assess. We're going to put her on the monitor and check the baby, do a non-stress test. We're going to check her cervix and see what she's dilated to. And then we're going to send her to walk, drink, relax, take a shower, whatever she wants. And then in a couple of hours, we can reassess her cervix. And if her cervix is the same and her contractions are irregular, she's going to probably go home. If her contractions are consistent and her cervix is making change, she's probably going to stay. Okay, so that's kind of how we can determine true versus false labor. Next, we have our stages and phases of labor. With our first stage of labor is from when labor starts until she is completely dilated. And completely dilated is 10 centimeters dilation. We have this broken down into phases. So the latent phase of the first stage of labor is going to be that first part where we're not making a lot of cervical change yet. We've got some slow progress maybe. And then we get to active, and technically active phase is considered 6 centimeters dilation. But truly an actively laboring patient will quickly progress to 6 centimeters. So with active labor, we're getting cervical change. She's having maybe a more difficult time coping, working harder to breathe through her contractions if she doesn't have an epidural or other pain management going on. And then we get to transition. In transition, we find usually this actually happens when they're around 8 centimeters dilated, and they start feeling this urge to push. They might say, I feel like I need to poop. They might start grunting, things like that. And this is when the body is transitioning from first stage to second stage. And that last little bit of cervix is going away. During this time, we really want to help moms cope with breathing through their contractions, blowing out, not bearing down, trying, if we can, to get her the rest of the way dilated. I don't want her to push before the cervix is gone, because the cervix can tear and bleed and we can have problems with that. So that's transition. And so when she's 10 centimeters dilated, that is the end of the first stage of labor. Second stage of labor happens next. And this is from when we're completely dilated until we deliver the baby. All right. So during this time, we are going to have her pushing. There's our other power. Okay. During pushing, we can do a lot of things to kind of help her. We can still be doing pain management as far as like massage and things like that to help her with her coping. We don't want to give IV pain medicine when we're close to delivering the baby, because it crosses through the placenta and can cause the baby to have respiratory depression. So we're doing a lot of non-pharmacological pain management unless her epidural is working really well. This is also a time to really do some good position changes. If she's able, getting her upright and kind of in a squatting position is going to help that baby descend. All right, let gravity help. the baby tucks their chin and comes through the pelvis, and we can get good progress that way. All right. Third stage of labor. So now in the third stage, the baby's born, and we're waiting for the placenta. We can wait up to 30 minutes for the placenta. During this time, we're not just, letting her hang out and we're ignoring this. We have a provider who's actively managing the delivery of the placenta. Because guys, the placenta is going to detach from the uterine wall. And when this happens, then the uterus needs to clamp down and tamponade those big vessels that have been feeding the placenta. Otherwise, we can have hemorrhage. So we have a provider expectantly and actively managing the delivery of the placenta, which is our third stage. Fourth stage is going to be the first 2 hours after delivery. And this is when baby's transitioning. This is when mom's transitioning. We're watching her blood pressure. We're watching her to make sure her bladder's not too full. We're facilitating breastfeeding and those things. And I think, let's talk about maternal comfort. So during labor, when we think about how we are managing her pain. Okay, so perception is a big part of this, and how a woman perceives the way her pain is. Somebody who's had a lot of painful experiences might view pain differently than someone who's never had pain before. Or somebody who's very young might perceive that pain differently than somebody who's older. Or different cultures experience pain and perceive pain in different ways. Background. If we have a woman who has a sexual abuse history, she is going to have a different perception of this experience than someone who doesn't. So there's so many different things that feed this. And so then when we're thinking about mom and we're thinking about her psychologic response, when we're talking about our peace, this is part of it. Okay, so a lot of what labor nurses do is around this. All right, so a couple of things we think about when we are thinking about maternal comfort in labor. Anything that's going to cause pain, I want to minimize. Anything that's going to cause anxiety, I want to minimize. One of those things, guys, is the vag exam. All right, it's a very intimate thing, and it's a very uncomfortable thing. So if it's going to change our plan, we might need to check our cervix, but we're not just doing it all the time. We're going to minimize those. And even still more so for those that have like that sexual abuse history and things like that. Outside of that, the other things that I'm thinking about is my pharmacologic and non-pharmacologic pain management. Non-pharmacologic is a huge part of OB. And this is one of the things you can carry with you into other modalities, is ways to help people cope with pain that's not a medication. Okay, a lot of this has to do with things like therapeutic touch, massage, water therapy, hot and cold position changes, and a lot of it is controlled breathing, helping them focus. For in labor, if I can get a mom to really focus on the way she's breathing, her mind is paying attention to the breathing. It's not paying as much attention to the pain she's dealing with. Another thing we think about with maternal comfort has to do with the gate control theory. So the idea behind the gate control theory is that if I'm stimulating positive chemoreceptors in the mom's body, the brain's not paying attention to the negative chemoreceptors. So basically, if I'm like stimulating pressure points, for example, I'm doing a good massage, things like that, then the body's noticing this and it's helping to minimize the perception of the painful part that they're experiencing. So that's another part of non-pharmacologic. Pharmacologic pain management, we can do things like IV pain medicines, morphine, Stadol, fentanyl. But again, we want to minimize those when we're like second stage or close to second stage, because they don't want to sedate the baby, and all of that's going to cross the placenta. So the other thing that moms have oftentimes for pain relief is going to be an epidural. The epidural is something that is placed into the epidural space, and it bathes the nerve roots with bupivacaine and a little bit of fentanyl. It doesn't go into the bloodstream, and it really decreases significantly the pain perception. And it's usually from about the belly button down. With an epidural, we have an increased risk of causing hypotension when we place it. So we have to be mindful of that, because if we create hypotension, how does that affect my baby? How am I perfusing the placenta? What might I see with my baby if mom's hypotensive? Okay. She's not going to be able to manage her own bladder. And we don't want the bladder to be full in labor. So we're either straight cathing or doing Foley's. She's a fall risk because that we have taken away her perception, or greatly decreased her perception in her legs. And for most with an epidural, they're not even getting out of bed, which comes back to our positioning that we can do in the bed to help moms in labor. And then, how's her pain doing? Is it working? Okay, so those are the things we're thinking about for our anesthesia. Spinal anesthesia is typically done for like scheduled C-sections, things like that. And the pudendal block is something that can happen for a mom if she is unmedicated, she's making great progress, the baby's coming down, we're close to delivery, she's having a lot of pain in her vaginal area and her perineum. The pudendal block puts pain medication in those nerves just down in that perineum. And that is maternal comfort. Fetal monitoring is something that we're going to have a separate video for. Okay, so watch for that. I think that is it for labor and birth. I hope you have a great day.